Good morning. Thank you for having me. Samuel Horr. I'm an interventional cardiologist, structural heart cardiologist in Nashville, Tennessee, at TriStar Centennial, which is a HCA facility. So my role today is to go over some cases and have a busy clinical practice and how Savvy has really impacted that clinical practice for me, how it's increased efficiency and improved patient outcomes. These are my disclosures. So for me, I like to put Savvy into three buckets. So when I'm thinking about if I'm going to adopt a new technology, it has to do a few things. It has to increase efficiency, it has to improve or not at least detract from clinical care, and it has to improve outcomes. So for me, trying to sell how to get this wire into my hospital, it does reduce the number of pieces of equipment that you need. It replaces the traditional TAVI wire, the Safari or the Lunderquist or the extra stiff, whatever you use. It gets rid of a transducer, it gets rid of a venous access kit, it gets rid of an RV pacing wire, and a closure device, if you use it, it also decreases the amount of time, so you don't have to hold pressure out in your recovery or your fellow, whoever holds pressure for you. Increases efficiency, so we're a place that does a lot of hemodynamics. We do pre-hemodynamics, post-hemodynamics, and we take a lot of stock into what that shows. For us, it reduces time as we're turning over rooms to set up transducers. It gets rid of, again, a pacing wire, which reduces the amount of time you have to be on fluoroscopy. And so I'm glad you showed that fluoroscopy slide where it actually reduced the amount of time. We've actually seen that quite a bit as well. And then we minimize exchanges. So when we deploy a valve, we can actually get instant hemodynamics to know whether I need to post-dilate that valve or not without having to take the delivery system out, put a pigtail catheter in, measure pressures, get the echosonographer in. I have a lot of hints about what that echo is going to show without ever having to do all those exchanges. And I think the other thing it does is it minimizes complications. So in my practice, at least, the two most common complications are going to be access site complications and then pericardial fusions. And most always the pericardial fusion is due to the RV pacing wire. And we've done a lot of things to try to change that, but haven't really reduced our pericardial fusions until we got Savvy. And so since we've had Savvy, we've had no pericardial fusions. And that's a direct thing that we've seen and can go back to our administration to say, this is how we're improving patient care. So, when you first start out with any new technology, you want to start with a relatively straightforward case. And so this is how we position it in the ventricle, just like we mentioned before. You want to make sure it's all the way out in the apex. It's a very supportive wire. It allows us to navigate very tortuous anatomy, very complex anatomy, horizontal, as you can see here, slightly horizontal. I would consider this a relatively straightforward case. You see that the wire provides enough support. This is the deployment of the valve, and what you notice is that as we push forward on the wire, the valve does come up a little bit, but the wire is supportive enough and it gives us enough time with the reliable pacing that we're able to advance that valve into appropriate position and deploy without missing a beat. And I think that proved to me in the first case that we did that this is a wire that I think is going to change the way I practice. So of course, when you first start out with a new technology, you do the easy cases, but then we're all very interested in, so immediately you start moving to more complex anatomy. And I think what I was surprised about when I used this is that even in complex anatomy, it's supportive. And so this is a patient. This is one of our early cases as well. It's a severe calcified valve. You see here we're planning to do a 23 balloon expandable valve. You see the STJ is not that friendly. It's a little bit small. It's circumferential calcium. The aorta, which you can see is tortuous, and you'll see in the next slide, it's actually a little bit even more tortuous than it looked like in the CT scan. So despite all those challenges, you can see here our pigtail catheter, as it goes down the descending aorta, is taking a large twist. And despite that, you see that we have great support, not a single concern at all in terms of support of the wire or missing pacing with a pretty standard deployment, which I think with some wires we would have struggled. We would have had to use either a very supportive wire to get through this anatomy and maybe compromised on the ability to be coaxial when you use a very supportive wire, or use a less supportive wire and lose the ability to push and pull the valve as you need to make those small changes. This is that same case. So this is early. This was a beautiful example of how we were able to take a patient with very severe aortic stenosis. You see a peak-to-peak gradient of over 70. And take that patient and give them a great result with a peak-to-peak over 3. And we thought this was a very good result in a 23 balloon expandable valve. So I think if you ask me where is this wire best, I would say valve and valve, right? So as minimalistic TAVR becomes a thing, we want to minimize what we do. Valve and valve is perfect. So this is a case in which you can have literally one single access. Radial, if you believe in cerebral protection device, but otherwise it's a single access procedure. You have all the things you need. You have hemodynamics, you have pacing, and you have valve deployment in one arterial access. And so, as I said, the most common complication for us is peripheral complications. And so by minimizing arterial access, minimizing venous access, it definitely has made this safer for us. So this is a valve and valve in an Epic super valve. We deployed the valve, and I don't show the whole thing. I forgot to save it. We did it under fluoro rather than a cine, but we're actually able to deploy this valve out of a valve. You see it's very restricted, and then we went on to frac the valve, all while using one access point. With the instant hemodynamics, we were able to see the drop in gradient and have a very good result.
That's pretty cool.
So again, we keep getting a little bit more challenging. I start, get comfortable with the valve, get comfortable with the wire, and then start pushing. So this is a patient with a bicuspid valve. You can see there's fusion between the non and the right with a very heavy calcium, very heavy calcified throughout the arch, and the annulus also had a significant amount of calcium with a lot of MAC. And this is the 78-year-old gentleman who, because of his peripheral vascular disease and other comorbidities, was not a surgical candidate. So despite that annulus that you can see on the right, we thought he was appropriate for a transcatheter. So you can see here, this is our balloon valvuloplasty. That incision was displaced. It was a 26 valve with large sinuses. And so we decided a balloon valvuloplasty. It was a bicuspid, all with very good support with the SavvyWire. And then we felt that even though there was annular calcium, that we thought a balloon expandable with the skirt would be a little safer here. And what you see in this deployment is it's a good deployment. What you'll see is on the left side, there's actually some underexpansion and some recoil, all from that calcium right where it extends into the annulus. And so what we did was we immediately pulled that catheter back. And again, I wish I saved a lot of these pictures. I think about it afterward. Yeah. But immediately what we saw was that the diastolic pressures were meeting on the SavvyWire. And so without anything, we just pulled the catheter back, pulled the balloon out of the valve. You immediately see the diastolic pressures are equal. And the gentleman has very severe peripheral vascular disease. So the question you bring up is this low diastolic due to peripheral vascular disease, or is it due to aortic regurgitation? But knowing that annulus was severely calcified, our first guess was, well, I think this is probably aortic regurgitation. So immediately we do an echocardiogram, and this shows it's at least mild PVL, but I would argue that if we did a TEE, it was probably more moderate, and the hemodynamics suggested that it was more moderate. So without taking our delivery catheter back, we were able to add a CC to the delivery system, post-dilate the valve. Again, you can see how it's underexpanded and sort of asymmetrically expanded previously, but by adding a CC, quick post-dilation, getting rid of the recoil, allowing better expansion, we were able to then quickly see the hemodynamics improved and there's no AR. And so I think this improved efficiency. This would have taken us an extra 10 minutes to get an echocardiogram in there, maybe do an LV gram or do an aortogram, maybe do pressure again with a pigtail catheter, but we were able to quickly diagnose the problem and give the patient a result. And so he was 78, and other than a few comorbidities, my expectation is he was going to live a long time, and I wanted to give him the best hemodynamic result while minimizing AR. And the Savvy was able to do that for me and be very efficient. So not only the tortuous aortas and the calcified aortas, you want to make sure that you have good support through the peripheral system. And so we frequently are pushing the envelope on what we can do with transfemoral access. And so this is a patient with pretty severe peripheral vascular disease. The left was worse, which I didn't show here, but the right side we thought was a reasonable access, very small but calcified. We were able to do lithotripsy, open up a good channel, and despite that, the valve, again, very good support through the anatomy. So for me, how I use Savvy in my practice is that it's streamlined. So it makes it more efficient. I don't have to take the time. We have lower radiation dose. We don't have to put an extra venous line in. I don't have fellows in my practice, so if it's holding pressure, it's going to be me, or it's going to be a nurse that may or may not be a traveler I may not have met, don't know how often they've held pressure. So if I can minimize access, it is going to minimize my complications. It doesn't compromise. It gives you the support of a good wire, but it also gives you all the hemodynamics that you want. We were able to assess for AR, as I showed that case right away. And then we use it in a couple of other scenarios that as we are looking at AS and moderate AS and evaluating the cath lab, frequently, especially as the dual lumen pigtail went away, and who knows when it'll go away again, we frequently use that for AS assessment in the cath lab. And so overall, I would say it's a great adoption into my practice. And